So thank you so much for inviting me to talk today. We were hoping to run a series of events, and then PCPA contacted us at NHS England and said, we're running an event, and I went, brilliant, let's do it together. So that's why we're here. And it's quite safe to say that 8 weeks ago, when we started this whole launch process, if I had known then what I know now, we might do things slightly differently, but learning is a wonderful thing. So, the clinical pharmacy pilot is within the context of the Workforce 10-point plan. And the Workforce 10-point plan is about supporting general practice and the staffing of general practice, but also GPs. And it splits into 3 parts: recruiting more GPs, retaining existing GPs, and looking at new ways of working as part of that, and returning GPs to practice. And what's interesting is that I've had the conversation with nurses, and it's a very similar story. So we know that it isn't working in general practice at the moment. I've got people who are looking at me, so I will use the mic. So we know that the staffing model in general practice isn't quite working at the moment. So the new ways of working, which is point 8, the clinical pharmacy pilots is the first of the pilots that will be in there, and we're not quite sure where we'll go with that. Obviously, the Secretary of State announced physicians' associates within that announcement in just after the election. So that's likely to be the next piece of work, but the clinical pharmacy pilot is definitely the largest that we've done for a long time. Oh, wrong way. So, so why are we doing it? We know, don't we, that clinical pharmacists make a big difference in general practice. There's examples of it. I've heard wonderful anecdotes, but it hasn't been spread across the country in a wide enough way. So we want to support that innovation, build on what's happening, and we want greater involvement of clinical pharmacists in a whole range of areas. And we do believe fundamentally that having clinical pharmacists in general practice will support patients, will make life better for patients, will help them get access. So I don't know if anyone's here from Bristol. It's quite a long way, Bristol to Leeds, no? The old school surgery in Bristol have had a clinical pharmacist there for a long time, and we've spoken to the GP and we've spoken to the clinical pharmacists there, and this is their view. It's a large inner city practice. You can see that from the numbers. Within a year of having a clinical pharmacist seeing their patients, those with type 2 diabetes, 82% of them were better. Not cured, because you don't, but, reduced glucose levels. You can see the figures there, and I'm not going to read it all through, but some of these endorsements that are coming through from our case studies that are going on the website today, and you've got your own stories, show just how valuable they are. And increasing the choice of patients, we've recently done a video in Staffordshire with Mani Hussain and his practice. And the patients are saying they prefer to see the clinical pharmacist. They get more time. They're able to talk about complex medication issues, the challenges of taking one medication versus another medication, some of the side effect management that they don't feel that they can have the conversation with GPs about. And here's another one, Karen Acott, who actually is a full partner in a GP practice, which is fabulous. And I think Karen is definitely part of the NAPC and is really keen to drive forward this work through that route as well. And again, slightly different model to the one in Bristol. So the bit that I think most people want to talk about today is this bit. So what will the pilot look like? We have worked a lot with CPPE, with the Keith Ridge, Bruce Warner and Sue Ambler to look at what the model would be. And
there's a view that this model of having a senior clinical pharmacist working with up to 5 less senior clinical pharmacists is probably the most sustainable and effective way forward, and gives a career progression pathway and also that clinical safety and supervision. So based on that, we have money for about 240 to 250 people, we think. So we anticipate that there'll be somewhere between 40 and 50 pilot sites. Originally, we'd said that these pharmacists would be recruited and employed by GP practices. And this is the learning for me, really. We would now say that provider organisations, any primary care provider organisation. So I've had inquiries from acute trusts that provide GP practice. Can they do it? I'd be open to a bid for that, or we'd be open to a bid for that. We've had federations, GP federations, asking, can they employ the pharmacists? I think we'd be open to that. I've had somewhere that is an organisation solely of pharmacists who deliver services into GP practices. Would we be open to a bid from that? We would be open to a bid from that, as well as what we'd originally envisaged, which was a group of GP practices coming together and saying, we'd like to employ some people. I don't want at this stage to rule out any opportunities. We're about innovation, we're about creativity. Let's have a look at what comes forward. Each individual pharmacist will come in with different skills and at a different point on a development journey. So CPPE have developed a development programme, which Chris is going to talk about. So each individual pharmacist will have a development programme. There will be practice development support. And again, we worked with a group of people to think through what that might be. We talked to pharmacists, we talked to GPs, we described something, and when the description came back from our partners who would deliver it, we weren't sure that it would really help embed those clinical pharmacists into the practices. So we've taken that to one side, and we're looking at the sort of in-practice development that we can provide that would be bespoke. So 250 practices potentially. You have to think very differently for each one. Even if I just, those models that I've just described, the type of support that would be needed by practices would be different. We're also going to run a longitudinal evaluation through this programme, and the evaluation, I think, is really critical. What we want from an evaluation partner is that at the end of the pilot process, they can say, this is where clinical pharmacists have made a difference, this is the value, this is what patients said. And so we're hoping that we could really make a compelling argument to the wider GP community who haven't been part of the pilot that actually clinical pharmacy is the way to go. So we've had a £15 million commitment. So those of you who know the RPS and the RCGP proposal originally was for £5 million. When we started working that up, it worked about 50 people. And we said, you need more people to make it evidence-based, to make it a really robust pilot. So we've got £15 million, and we see this as a contribution to the cost of salaries, to help practices embed a new role within them. I've had some very interesting questions on the inquiries inbox about that, but it is, for me, a transition payment to support practices. 60% in year 1, 40% in year 2, 20% in year 3, and nothing in year 4. And I think we often forget there's nothing in year 4, but there's an expectation that years 4, 5, 6, etc. will continue. This isn't a 3 years and make them redundant pilot. What we will be looking for is something that is about a sustainable model. So we will need practices to evidence, or employers to evidence, how this will be sustained in the future. And the training is fully funded. I just want to be really clear. The training is fully funded. If the pharmacist does not yet have non-medical prescriber qualification, the Let Be will fund that. So I'm just saying it's fully funded. Development programme for practices will be funded, and the evaluation is funded. So we launched on the 7th of July, which feels like it was a really long time ago now. And we wanted to launch early with a long run over the summer so that people could really think about what their model might be, who they might need to work with, who their partners might be. We put quite a lot of material on the NHS England website, and we opened an advice mailbox. So the material on the website has been refreshed, and we would encourage people to go back to it, and there will be a further refresh of it by close of play today, or I'm looking at our comms person, close of play today? 10 o'clock tomorrow morning. So there'll be a refresh of that very soon. And what we are hoping to do is to put up some more guidance about how to apply, and I will go into that a little bit more in a second. We've got an application window that covers a whole weekend, because in the past we've often done Monday to Friday, but we've been advised that a whole weekend is better as well. So 11th to the 17th of September is quite a long application window for NHS England type submissions. And once the submissions come in, the NHS England regional teams and the LETBs will work together locally, using their local knowledge, to sift a first cut of suggested pilots. They will put forward their proposals to a national moderating panel, who will then look at the parity across the country, whether or not there is a diversity of ideas. So if all of the models coming forward are the same, we may want to look at some different nuances. We will want to look at the spread across the country. And then the week of the 2nd of November, there will be an announcement. So I'll just talk a little bit about how to apply. Historically, when you've applied for things with NHS England, or before that, the Commissioning Board, or before that, the SHA, you sent an email. And what often happened was that emails got lost when they were being sent on to other people. 3 emails were sent for the same bid, the email boxes crashed. And we wanted to make it a simple process for both the practices or employing organisations who are putting forward a bid, and for those people who are assessing the applications. And so we've spoken to a lot of people, and we think that the best approach is a SharePoint facility. So this is access to the NHS England extranet. So people would have to register for a Microsoft Online account. So for those who have intranets already, if it's a Microsoft 365 site, you'll be able to use the existing email address that you have. If not, it's very simple. Click a button, register an email address for a Microsoft Online account. You then send an email from that email address to our inquiries line, and our new fabulous member of staff, Danique, is going to then give people access to the SharePoint site. You'll get confirmation that you've got access to the site, and then from the 11th of September to the 17th of September, you'll be able to apply online. So it's the same application form. There is almost nothing different. I'll explain what the differences are, but it's an online form. So rather than filling in a box in a Word document, you will fill it in online, just as you do when you do online shopping, etc. You can save it and come back to it later, so if you aren't sure. But what it does do is it stops submission of incomplete applications, and it stops resubmission of the same application, and it keeps it all in one place for the providers. I used to work in a PCT, and I've done bids before, and I'd do a bit, and then I'd send an email to somebody else, and they'd do a bit, and then there's version control. There's no need to concern about version control. It's all in one place. And you submit when you're ready to submit, as long as it's by 5 o'clock on the 17th of September. We'll allow 1 SharePoint login per application to manage the version control, but you know, who you share the password and email address with locally is up to you. So we've already got a lot of resources on the NHS England website, and we link through to the RPS website. I'm delighted that we're going to link through to the PCPA website now, and this guide for GPs considering employing a practice pharmacist is fabulous and will be one of the resources that we offer to GP practices. So I hope we'll link through to you as well. We're updating the FAQs today. The key FAQs that I've had recently are who can employ. I think I've covered that one. Indemnity, and I'm really hoping we pick that up at the Q&As maybe. Who's going to pick up the redundancy costs? And we've said this isn't about making people redundant. This is support for, and I won't rehearse what I said earlier on, you heard me. And they are really the key three questions that I've had, that and the cost of training, or what the training consists of, and Chris is going to pick that up. But if you have further questions, if I have the answers, I will try and answer you, and if I don't know, we'll take a note and we'll come back to you. Oh, I've lost it now, that's it, that's gone. So that's the process, that's what we're looking for. I think in terms of putting in a good application, we want innovation. We want to see something that is creative. We will support applications where there is demonstration of need. So areas of the country where they're struggling to recruit GPs, where there are vacancies, where outcomes for patients may be more challenging. Need is defined differently in different areas. Need in London is different to need in Leeds or Manchester. So there's something about tailoring, and that's why the local NHS England regional teams and LETBs will be making that decision locally first, because they know what matters to them locally and will fit in with their local strategic plans for primary care. Where CCGs have been given devolved responsibility for commissioning or co-commissioning of primary care, they will also be involved in the decision-making process and will be engaged, and patients or patient representatives will also be engaged locally as well, because we need to be assured that this is going to work for the local communities. I said I'd mention the changes on the application form. So originally on the application form, we asked for the practice code. We're not asking for the practice code, but we are asking bidders to be clear about which NHS England regional team they come under. So there'll be a drop-down list, and there's a fabulous website, the National Performers List website. If you put in a postcode, it will tell you which regional team, so it's not massively complicated. We are going to ask those who put in applications what sort of development support they see they might need to embed this role into their team. And we want to do that so that we can tailor and bespoke that in-practice development programme that we're commissioning. I felt a little bit like we were giving the pills before we diagnosed the patient. So I wanted to make sure that we really, really understood what was going on. And I think they're the changes on the application form. So they're very, very minor and hopefully much more helpful, subject to the conversation about indemnity at the Q&As. Is that okay? Yeah.
Thanks, Rachel. I think we probably do have time for one. Do you want to take one or two questions now? Because we've got a bit of time, haven't we? If there's any burning questions now, happy to take one or two. So,
okay.
Okay, so my question was really around the regional distribution. Sorry, Graham Stretch from Argyle Surgery in London. The regional distribution was my question, because initially when I read through it, I felt that most of these monies would likely go to places where you felt there was a shortage of GPs, which is probably not so in London. But I think obviously London would like to make things. Do you think that areas where there isn't such a shortage would be excluded, or would you perhaps apply the criteria to applications from areas where there isn't that shortage?
We, at the moment, haven't said that there will be a specific allocation for regions. We haven't said that. We've discussed it, we've discussed the merits of it. But I think the view is that we want to judge each pilot on its own merit. So if a pilot comes in and you can demonstrate within that bid real need within your area, I know that there are practices in London that struggle to recruit. So if you're a practice in London and you're struggling to recruit and you can demonstrate how this role would really add value, then I think it's worth putting a bid in. Regional teams will know what they're looking for in a local bid, and I do think that it's worth a conversation with regional teams about what it is that they would support. I don't know what they're looking for in London, I'm not close to it. We're a national organisation. I don't think that we would not support bids that are in London. I think there might be equity across the country.
Hi, can I ask you a question? Liz Butterfield, I'm a primary care pharmacist in Brighton, so I have come quite a long way. Not sure it's on. I wanted to ask you a bit more about the evaluation. It would be great to see the evaluation include something about improved outcomes for patients from their medicines and real take-up of medicines optimisation principles that NHS England is driving forward. So it would be great to hear that the evaluation is going to be quite ambitious. In other words, we're looking for quality improvements in the way medicines are used and the outcomes patients get, as well as just an extra bit of workforce.
So the evaluation spec has been created by pharmacists and academics and managers and GPs all working together to understand what they each need. And Bruce Warner has had a very heavy influence on the evaluation spec. And if I tell you that I think the first or second line in the outcomes is the impact, medicines optimisation is embedded in the practice, or some words like that. So absolutely, medicines optimisation is a key part of that. When we have, we're imminently going to send out the evaluation specification. Once it has been put onto the portal where we upload these specifications, we will also put it onto the NHS England website so that you can see what it is that we are going to evaluate. There are some things that I've said in the evaluation. We want academic rigour behind it, so we will want pharmacy school, medical school input into the evaluation. We have said that there must be as minimal impact on the surgery as possible. So what we don't want are evaluation approaches that mean that everybody in the surgery fills in a questionnaire every week, and we just don't have capacity and time to do that. We don't want the evaluation to be something that detracts from the impact of the clinical pharmacist being there. Within the application, sites will indicate what outcomes they expect to achieve by having a clinical pharmacist in there. So there's 2 national committed ones, and then there are 8 to 10 we're saying between 8 and 12 in total, so 6 more to 10 more. So obviously we need to gather that information and assess that, but this is about what does fertile ground for a clinical pharmacist look like? How can we evidence that there is real value to clinical pharmacists in general practice, and so that it sells a compelling story to the general practice population in the future? So I hope that reassures you a little bit about the rigour of the evaluation. But
yeah, thank you. It's good to know we'll be able to see the scope of it beforehand. So
yes.
Thanks very much.